Nice to see a lot of you here. This is 2 days in a row of major public health events. We're wiped out. This is it. We're all going to sleep after today's event. But I'm really glad we're having today's event. And I'm glad that I want to thank Dr. Stevens for having instituted a new public health institution. And it is, you know, some of you know that we have a library that has a Book of the Year award. Well, now we have a public health book read, we call it. And hopefully we'll continue it each year, so that each year we'll pick a book that is relevant to students in public health and the larger pictures. There's no limit to them. They come out many each year. This year we had a little vote amongst the faculty. We picked this one, and you're going to learn about the larger problems of the healthcare system, much as you would learn in, say, Dr. Lott's health systems course, or Dr. Stevens' public policy course, or some other things in public health. But mostly that's where this book would fit in. They call it health services in public health. So we have a lot about that. I've read almost all the book. I'm not to the last chapter, but I've read most of it. And there are some wonderful stories. I like the fact that the book it's not really written for an academic audience, I think it's fair to say. It's written for a layperson audience. So people who are not healthcare experts can see what the problems are. And so there are a lot of things in there that some academics, me not being one of them, would say, this is an anecdote. What value is an anecdote? It's just a story of one thing that happened, right? We have to have systematic research. We have to have at least 500 studies to be able to make a conclusion like this. But the book is filled with some really interesting stories that are bigger than anecdotes that we all know are true, and they happen. But they're examples of flaws in the system, which Dr. Fine then goes on to expand upon. But he's not afraid to use an anecdote when a lot of academicians can't even use an anecdote sometimes. So the book, I think, is written for people who are not experts, to make them think about the problems in the system and how it works. And I think, therefore, it keeps the big picture of healthcare in mind. And those of us who've worked on trying to fix the big picture know how big the picture is and how complicated the picture is. That you can't just say, let's fix this piece of the healthcare system. It's like that row of dominoes, you know, when you know that game where you push one domino and the whole row. Well, sometimes if you push one button in the healthcare system, the whole system changes. Maybe for the better, maybe for the worse. So you have to be very careful on advocating health reform, because it's so big, so interconnected, so much money, so many people dependent upon it. It's when I used to work in Sacramento, when I was head of an organization of managed care organizations, a lot of HMOs, everybody would come to us and say, this is the year of health reform. This is the year health reform is going to be big. And I remember thinking to myself, you told me that for the last 10 years. Health reform is always big. There's never a year where people aren't screaming and yelling about health reform. It's common, you know. It's like getting up in the morning in politics and health policy. Okay, so I'm glad you're here. We're gonna hear from you. I wanted to say, there was one thing I thought about in the book that I'd like you to maybe address. I mentioned it yesterday. The one thing that struck me is that the question is, there's clearly a lot wrong with the healthcare system. The only difference is whether you're viewing it from the left or viewing it from the right or somewhere else, it's different things that are wrong. But everybody knows there are things wrong with the healthcare system. Just depends on what viewpoint you take as to which of those things you're going to emphasize, or which of those things are wrong when someone else thinks they're right. But one thing that struck me about the book, and I've been through this in a lot of other discussions with people, is a question to ask yourself is the problem being described a problem that is the healthcare system? Is it something specifically wrong with the way our health system is organized and structured? Or is the problem, for example, that Americans don't have the life expectancy of Japanese? Or too many African-American women have pre-births, premature babies. And they die sometimes. The death rates are much higher, right? Sometimes I have to question myself, is that the healthcare system? Or is that the values of our larger framework, the way we view things, that causes this kind of a problem? Okay, so from there, here is Melina, the head of our president of our student association. Melina Rodriguez is going to talk to us a little bit about whatever she wants to talk to us about.
Thank you, Dr. Zelman. So I'm just here to kind of welcome everyone on behalf of the Public Health Student Association. If you've been doing or participating in these events with us, you might know we did one back in February, and we had Dr. Stevens and Dr. Law do a discussion, and that went really well. And the next one we had in March with Dr. Paul Song, and he kind of really talked about the importance of advocating for, public health care for everyone. That was virtual as well, so it's really exciting to finally be in person and see everybody. Even though we're masked, I can recognize some of you from your eyes. So, that was our role basically in helping Dr. Stevens and the Public Health Department facilitate this book read. We kind of just made sure we were promoting it and telling students about it. So in case you didn't know, what does PHSA do? Stuff like that, right? We do that. And I wanted to remind everyone what our mission is. So we really work to provide students in the Public Health Department with different opportunities, growth opportunities, learning opportunities. We also try to advocate for the needs of students, not just in education, but in their overall well-being. And we also work to create sort of like an outlet for networking and connecting. So this book read definitely did that. I mean, look at all of us here. There's graduate students here, there's alumni here, there's faculty here. So it's a really, really awesome opportunity. And in regards to focusing on the well-being of everyone, obviously we all need healthcare, right? And a lot of us, I think, might have been through a period where we didn't have healthcare. I know I didn't for a few years. So learning about how we can each participate and take action and advocate for that is really, really important. So I hope that we've all kind of learned a little bit more about that while participating in this book read too. So the last thing that I wanted to say is just kind of like a personal reflection on the book. I also haven't finished it fully, so you're not the only one, Dr. Zelman, but what I have read just kind of really reminded me of why I went to public health in the first place. I did start off as an organizer a while back, so I'm familiar with organizing, but I think for those who haven't organized, I think hopefully this inspired you to really, really take action and kind of find an outlet, because it's up to all of us to do something about this problem, right? It's not just, oh, we have to wait for the government or we have to wait for someone to tell me what to do. It's kind of really that collective and community effort, and your book really, really highlights that. And our department is focused on community health, so I think it's really important to remember that as we discuss the event today and everything. So I'll let Dr. Stevens take over, and then finally we'll get to our wonderful discussion with Dr. Fine. Thank you.
All right. Thank you very much, Melina. Thank you, Dr. Zelman. I'm going to set an example here and take off my mask to allow Dr. Fine to take off his mask for the presentation. I don't normally speak off of speeches, written down speeches, but I wanted to get this introduction right. So if you don't mind, I'm going to look at my notes while I'm introducing Dr. Fine. Our Department of Public Health, we created this book read with a purpose. And that purpose was to unite around something singular, to bring our students and our faculty together. And I think we did that by uniting around a book. And I think we couldn't have picked a better book to suit that purpose. It's unique, it challenges the status quo, and it invites us into action. As so many of you know, the book Health Care Revolt, written by Dr. Fine, is also infuriating. I would argue it's enraging. I feel angry when I read that book. Anybody else Okay, lots of hands. Okay, great. Yep. And that's because, so many members of our community have experienced the limits of healthcare. We train some of the world's best doctors, physician assistants, nurses, and others, but we don't make them available to everyone. We ask them to treat patients differently based on their insurance or lack thereof. And most importantly, we inculcate them into a marketplace that makes them chasers of profit first and healers second. This wears on both doctors and patients. I call it a moral injury of sorts. It's where both the deliverers and the receivers of medicine become skeptical, distrusting, and sometimes even lost. But there are solutions, and that's why we invited Dr. Fine. He's been a part of this book, the semester-long book read, since the beginning, advising us, suggesting events, suggesting ways to advertise this. So he's been deeply engaged. But before I hand it over to Dr. Fine, I just want to say a big thank you to all of you for participating in this. There's no such thing as a department-wide book read until the department reads the book, including the students and the staff and the faculty. Agreed. I want to thank Melina and our Public Health Student Association for really taking the lead on all of the events, and for producing all the beautiful flyers that have gone around. And thank you to Caroline Trejo from our department, who's really just managed every single step of this process. So thank you for that. If you don't have a copy of the book for any reason, if you just happen to find this event today, there's copies in the back for free for you to take. Please grab one on the way out. Now, Dr. Fine describes himself as a writer, a recovering family physician, and a public health provocateur. He's a former public health official. He was the director of the Rhode Island Department of Health for 4 years, and he's currently the chief health strategist of the city of Central Falls, Rhode Island. I met him many years ago when we were both hawking our book at the American Public Health Association annual meeting. We stood outside and chatted, I think, for maybe an hour while the session was going in, and found we had a lot in common. We've stayed in touch since then. This was probably well over a decade ago. I consider him a friend, and I'd like to invite you to help me welcome him today. Thanks, Dr. Fine.
Okay. Thank you, Dr. Stevens, for that amazing introduction. And thank you all for being here today, not just to hear this talk, but for being involved in the public health process, because you are the solution to the problem that we collectively have. Dr. Zelman, 500 studies have been done, and I'm going to talk about some of them. We haven't learned from them, but they've been done. And I don't think the problem has anything to do with health or healthcare. I think it has to do with politics and democracy. And that's what we're here to talk about. That's what I'm here to talk about. And what I'm here to talk about and what I'm here to say is that the way we're going to fix healthcare is to resurrect democracy before we lose it, and that the people in this room are the Jedi Knights to get that done. So I'm going to start by reading a quote from a book I just stumbled into this quote a couple of days ago. Today, over 11% of our gross national product goes to healthcare, and we rank #1 in the world in per capita healthcare expenditures. Yet we remain behind other industrialized countries in life expectancy, and in the developed world, we rank 22nd in infant mortality rates. Who do you think said that, and when? Anybody have any guess? Faculty are not allowed to, you guys probably know. Anybody want to guess who said it and when? Okay, I'll make it. Is there a guess in the back? No? So it's simple. George H.W. Bush, Poppy Bush, in 1989. We knew this problem 33 years ago, and all we have done in the last 33 years is admire the problem. What I'm going to ask as we go forward is the question, is the purpose of public health and health policy just to measure outcomes and admire problems? Or is the purpose of public health and health policy to improve health outcomes and strengthen democracy itself? So, to update from George H.W. Bush 33 years ago, we do perform poorly compared to other advanced nations. They pay as little as 60% less than we pay, measured as cost per person per year. But their infant mortality rates are a third of ours, and that's for white women. Their infant mortality rates for their population compared to black women are 9 times better than ours. 9 times. And their life expectancy on average is 4 years longer. We are 64th in the world for life expectancy now and falling. And we are 50th in the world for infant mortality, no longer 22nd. And we have huge health disparities based on race, culture, ability, location, and other factors. That's in the United States of America, likely the richest country in the world. Now, I'm going to run through a bunch of quick charts and graphs from some of those 500 studies that have already been done, because I don't want to spend a lot of time admiring the problem. Our costs keep rising. Our life expectancy keeps falling. You know, this is the United States looking at life expectancy compared to health expenditure. We spend more than anybody else, and our life expectancy is, as I said, falling. We spend or waste about $2 trillion a year unnecessarily. That's actually about $6,000 per person per year. $6,000. So if you compare us to other countries, what we're seeing is wealth extraction at an outrageous rate. Every person in this room is used as an excuse to transfer $6,000 from the pockets of, or from the public coffers to private profit. $6,000. Family of 4, $24,000 a year. What could you do for that amount of money? Lots. And then the people who have something to sell take 0.05% of that and use it for lobbying. That's $500 million a year. And $500 million a year gets their legislators to pay attention to them instead of paying attention to you. When I was the director of the Department of Health in Rhode Island, I had to work through an application from CVS, which is headquartered in Rhode Island, to bring minute clinics to Rhode Island. Now, I'm a primary care militant, and everybody thought I was going to stop it. Now, when I looked at the application, I didn't have the statutory authority, and I certainly didn't have the political support. So I quietly hinted to friends and colleagues that they needed to put 100 people in white coats on the steps of the Capitol, because I knew if I got that, I would have some leverage to change it. I ended up approving the application, but with conditions. CVS didn't like the conditions, and so the CEO of CVS called the governor 3 or 4 times a day until those conditions were made to go away. The CEO of CVS got through when he called. How many of you would get through to the governor of California if you called? How many people in Rhode Island, a much smaller place, could even get through to the governor when they call? I know the governor, and I know the answer is basically 0. That's what money in our system does, and that's what's happening to democracy itself because of the money in healthcare. The money we waste unnecessarily on healthcare is also money we aren't investing in social programs like education and safe and healthy housing and public transportation and community development. And it turns out, when you begin to understand how health outcomes work, that those are the things that matter for health outcomes. Those are the things that matter. And Dr. Zelman, this kind of gets to your question. Those are the things that matter for infant mortality and life expectancy and the other things that we want from the public health so-called system. And I say so-called because you'll hear me say over and over again, what we have is not a system, it's a market, and it's a market that's there to extract wealth. So we're spending a huge amount of money on medical care, and that money is coming out of public coffers as profit, and that money is used to both enrich people who already have plenty of money and also are used to undermine the process of democracy itself. This is just a picture of how that works. Everything is being scavenged by the healthcare profiteers. Spiraling costs have contributed to income inequality. And if you think Obamacare fixed this, look at the timing, because income inequality has rapidly increased after Obamacare passed in 2009, 2010, and actually passed in 2010. People aren't getting primary care or prevention. Only 43% of Americans had any kind of primary care in 2019, before the pandemic. Visits to primary care physicians declined 24%. 52 to 54% of insured Rhode Islanders, and I use Rhode Island because I was able to call up some CEOs of health plans and get this data. 52 to 54% of insured Rhode Islanders had had a preventive exam in the last 2 years, which is a reasonable measure of whether primary care is working. 45% of millennials can't identify a primary care clinician at all, and this is not for once to beat up on millennials. It's to beat up on the crazy world that we've created where you can't get an appointment most of the time if you have insurance. And you're not treated with much decency, and if you're sick today, often you call up and get told, come in 2 weeks. Well, what good does that do you? Because you got better by yourself. And even 75% of people with Medicare, who all have insurance, only 75% have a primary care clinician. That means 25% don't. That's even people with insurance. And that ought to give pause to my friends and colleagues who I think the world of, but who think single payer is the solution to this. Medicare is a single payer, but it's not adequate. Having a single payer is not adequate to change health outcomes because people don't use preventive care unless we change what we're doing and how we do it. We have 145 million emergency department visits a year in the United States. That's almost half of us go to the emergency department every year, and that's likely because they have no other reasonable access. But that also means huge added cost with no real prevention. And we failed miserably at COVID. We've had more than 1 million deaths. Likely, when you compare us to other advanced nations who did way better than we did, likely 900,000 of those million deaths were preventable. And that happened not because we didn't understand how, from a public health perspective, how to prevent the transmission of the disease. That happened because we have central and dangerous political problems, because we can't agree with each other enough to do what's reasonable to protect all of the community that needs to be protected. That gets to values. We're in a dangerous place, and we're in a dangerous place because at this point in our history, we don't think protecting the health of elders and the most vulnerable matters. We're ready to write them off so we can keep hospitals open. Now, keeping hospitals open is important. We're ready to write them off so we can keep businesses open. You know, if I was in the position to make the decision, I would have taken keeping people alive over keeping restaurants and pizza parlors open any moment, any time of the day and any time in history. But we made another choice because of the pressure of people with money, the political pressure who wanted to protect their incomes instead of protect each other. But that puts us in a really dangerous place as a people, because if we don't value human life and value human life first, then I think we have to be worried about political violence and other kinds of things that will make our society potentially ungovernable. Now, we have failed to fix this mess for 50 years. We've tried all sorts of things, and I've listed them on this slide, and I won't even read them, but I've been through most of them. Dr. Zelman, I think, has been through a fair number of them himself. But, you know, all these bright ideas from policy people, they're very nice. They usually have nifty little initials, and they haven't worked for 1 second, including the family medicine movement. You know, I'm a family physician. It was conceptualized as a way to build a healthcare system for the United States, and it didn't do that. It got tracked off into doing other things like managed care and academics. Even attempts to build a social movement to create a healthcare system that's for people, not for profit in the U.S. have also failed, from single payer, as I said, to the family medicine movement, to the Health Security Act of 1993, which didn't pass. The Affordable Care Act made more people got more people insurance, which was a good thing, but it also was associated with huge increase in costs, which were all predictable, et cetera, et cetera, et cetera. Our attempts to build something like a bit of a social movement haven't succeeded. And so something ought to be done, but by who? Well, the bad news is that this won't change unless you change it. My generation of people blew it. We didn't deliver on the hope and dream of a healthcare system that's for people, not for profit. And we didn't deliver on it because we let ourselves get picked apart by politics instead of keeping our eyes on the prize. The good news is that this is changeable. You know, if you look at other countries, the science behind how you deliver health care has been known since 1978 or 1979. There's a famous conference in Alma-Ata, which is now Almaty, in Kazakhstan, run by the WHO, which looked at how you build healthcare systems that are effective and matter. And they figured out you do it based on primary care and making sure everybody has primary care. Other countries have done this, and I can list a whole bunch of other countries, from Finland to Spain to Portugal to Costa Rica. You know, those are the folks who did it, and those are the folks who have good outcomes because it's not complicated. This is a doable thing. But what we need is leadership and the courage of the people in this room to actually make the change. So that's the bad news. Well, that's the good news, is you can change it if you really try. The difficult news is that it won't change by itself unless you change it. I'm really sorry to tell you that. I'm really sorry to ask you to do one more thing. I'm embarrassed that people in your generation have student loans and have to pay to go to college. I'm embarrassed that the education system we handed you isn't adequate. I'm embarrassed that it costs too much to live. It costs too much to get housing and food. And I'm embarrassed that we're asking you to do one more thing. And it's not so much that I'm really asking you. This is, you know, the problem is not that I want to lay one more thing on your heads. The problem is that if you don't do it, it doesn't get done. We blew it, my generation. I'm sorry to hand you a problem, but the best thing I can do is tell you about the problem, tell you what we need to do together, and then stand behind you as you lead the way to take over from us and do what we failed to do. And more bad news. You don't change a 4.5 trillion industry by just asking it to change. You change a $4.5 trillion industry by building a national movement to change it. And let me tell you, building a movement takes work and time and years, and it stinks and it's not fair. There's just no other way. So how are we going to do it, and what are we going to do? Well, first of all, we put our eyes on the prize. The prize is a healthcare system that's for people, not for profit, that provides equal healthcare for all Americans equally, and that strengthens our democracy. The prize is what every other reasonable, civilized country has, and that we don't have, but we desperately need. We do this by building a movement in every community, starting in kitchens and living rooms and on porches, building neighborhood health alliances, and I'll talk about that in a moment, building citywide coalitions, building statewide organizations, and designing state-by-state healthcare systems, and then building a national movement to bring healthcare that is for people and not for profit to every single neighborhood, community, state, and territory, and leaving no one out. Now, if you think movement building is impossible, I will answer, or if you say that, I'll answer, it's difficult. It takes years and the involvement of millions of people. And that's very intimidating. But if you look backward in American history, remember the abolitionist movement, the movement for women's suffrage, the labor union movement, the civil rights movement, the anti-war movement, and the movement for marriage equality. Every 20 or 30 years in the United States, we have mounted a social movement to take what the founders gave us, those white guys who are mostly Southern farmers and liked the idea of being equal with each other. We have taken that idea of equality and gently, sometimes not so gently, progressively, but way too slowly, in bits and pieces, expanded it and included other people. Each of those movements involved millions of people in years. But by doing that, by having those movements, each of those movements not only improved democracy, each of those movements was democracy. By building a social movement, we recharge democracy that tends to get kind of stuck. But by building a social movement, we blow it up, open it up, and make it go again. And boy, am I worried about democracy right now. And boy, do I think we need to open it up, blow it up a little bit, and make it work again. And I think healthcare is a perfect focus for bringing democracy back. So what am I going to ask you to do? I'm going to ask you to do a couple of things, or suggest a couple of things, which basically start with the notion that came from the HIV activists in the early 80s, and that is act up. HIV care wasn't going to happen. It was going to be ignored until people with the disease or at risk for the disease took it to the streets. They did a great job, and we all need to learn from that. So there are 9 things that I'm going to tell you that you can do today. Remember that this movement is going to take years to build. It's not going to happen overnight. It's not going to be easy, but it won't happen, or it won't start till everyone in this room starts to start it. First, you can use your public health voice. That's why I think the people in this room are so important, because you know and understand the data. You are trained to look at these charts and graphs and understand them and translate them into the lives of everyday Americans. So you need to help people understand the cost, the $6,000 per person per year, this wealth transfer of public money into private pockets. You need to help people understand that they are having shorter lives There's more illness for everybody. This is harder on the poor and people of color because we haven't stood up and demanded a healthcare system to care for all Americans. And you need to help people understand that democracy has been undermined as the rich use healthcare to get themselves richer and reduce access to the political process that they have saved for themselves. You can use your public health voice by starting in kitchens and living rooms, and also help people understand that there is hope, that we can build a healthcare system that's for people, not for profit. Help people imagine what that system looks like. We just can't see it anymore because we have developed the oppression of underdevelopment. We've learned to live with what this thing is for so long that we can't imagine a healthcare system that takes care of everybody, that provides equal health care for all Americans equally, and that in fact strengthens the democracy at the end of the day. Second thing, both as individuals, as a part of your classworks and assignments and capstone projects and so forth, help us compile neighborhood data and share it. Once upon a time, when I was at the Department of Health, we were asked to do public health accreditation. And I think you guys are going through accreditation of its own sort. Our public health accreditation required us to do a community health assessment. Now, the typical way of doing a community health assessment was to sort of compile a bunch of data based on, on data that we had, put it in a big notebook, and send it off to the accrediting body to say we had done it. But we chose to do something different. We went community by community. We first met with people and listened to people. We compiled some data, but we started talking about the assets and gifts that the community had, the strengths the community had. So we weren't, as a Department of Health, giving communities problems that they didn't know they had and only we could fix. Instead, we started with what they knew about themselves and their own lives. And then we added some public health data which pointed out some possible challenges. We brought people together into a big meeting. We had 100 people in a little restaurant called La Casona on Broad Street in Central Falls is the first one we did. Central Falls is a city where I still work. It's 70% Latino, 10% people of color, the poorest community in the state, the one most affected by COVID-19 in the state, in the nation, and for a while in the world at the end of the day. But we brought everybody together, listened to what they told us. And what they told us based on the data was that they wanted three things. They wanted to make sure their kids were safe in schools because this was right after Sandy Hook. They wanted a place where they could get physical exercise because the city had been through a bankruptcy and their community center had been taken away from them. And they wanted better access to primary care. Now, out of that conversation came the development of the second neighborhood health station in the United States, a single place that has the capacity to provide primary care, primary medical care, dental care, mental behavioral health care, substance use disorder treatment, for the entire population of the place. It doesn't work as well as I'd like it to work, but it got going, and it is kind of a flagship and has reignited people's excitement about their community because there's a place now for people to go. That happened because we took public health data and sat down, we developed it thoughtfully for that community and sat down with the community and listened. And I think that is something that public health folks here could do. And then not only do informal meetings, but also share that data in kitchens and on porches, in workplaces and community meetings, so people understand where they're at, what they can do, and how to get there. We can as public health people, build health alliances. Right now, the Situate Health Alliance Board is meeting in Little Situate, Rhode Island, a community of 10,000 people. That's been in place for more than 20 years. Little Situate, Rhode Island, 10,000 people, pretty rural, a little rural-ish, about 15 miles from Providence, Rhode Island, is the only community that I know of where everyone's guaranteed access to primary medical and dental care. I can spend a long time telling you about how we got there, but the Situate Health Alliance runs vaccination programs. They give out tick tubes because we are a community that has lots and lots of Lyme disease. They've run well baby clinics, and they've run exercise programs for the elderly. That's a bunch of volunteers who get together once a month and figure out how to get all this stuff done. They also built a neighborhood health station as a result of their work together. This is a doable thing, and the people who are best able to lead that in LA are the people in this room. I think you can help us fight for equal representation at all levels. Shouldn't the student, staff, and board of every hospital, health professional training institution, healthcare nonprofit, every single healthcare institution, shouldn't the students and board and CEOs and C-suite look like the community that it serves? Let me tell you, I have been to that mountain. I know those folks, and that is not how it works. You know, usually the people at the front desk look like the community that the place serves and get paid the lowest. But you go to the C-suite, and it is a different story. That's where the money is, but it is not money that stays in the community. It is money that leaves the community, because that's one clear example of a wealth extraction system where these institutions, well-intended, many of them, but what they actually do is take money out of communities that really need resources and bring it to communities where there's plenty of resource already. It is important for you guys to get leadership training and join boards. Not many people know federally qualified community health centers have to be 51%, their boards have to be 51% consumers of their health care. With a little bit of agitation, people can get on boards and ought to. And sometimes that takes acting up a little bit. Sometimes that takes threatening boycotts. But let me tell you, you threaten a boycott, and in 5 seconds they'll be there putting people from these communities on their boards, and then they have the capacity to change these organizations and agencies. In Rhode Island, we have a couple of leadership training programs, one called New Leaders Council, another called Leadership Rhode Island, where people who are in business and in academics often get together and spend a day a month and basically develop networking. I've never seen a public health person as part of that process. But boy, that's how power happens. And you can get there, and you can get those connections, and then you can help change things. It's important for you to be able to tell the truth about what we've got, to go and testify. I've only been here 2 days, but I already know that the Board of Supervisors meets every Tuesday afternoon. And let me tell you, I don't know how the Board of Supervisors here works, but the legislature in Rhode Island, and I suspect the legislature here, listens in a different way when somebody with healthcare training shows up and gives them numbers that are meaningful. We need you guys to be able to do that, to show up, testify, and hold their feet to the fire. I think it's important for healthcare workers to unionize. The National Nurses Union has done a great job organizing for patient care and advocating for patient care we need other health professionals to do the same thing because there is strength in numbers. And that includes physicians, by the way. Once upon a time, not so long ago, 20 years ago, 80% of physicians were in private practice and were functionally local business people. Now 80% of physicians are employees, and they are rife for unionization if they have the support of their communities. And finally, people need to act together, to organize teach-ins, to create and share data, to run these kind of vaccination clinics and childbirth classes and so on and so forth, to be the spark plugs of community health in their own communities, listening to community. And what I'm going to do now is take you through, standing on one leg, what it's like to do community organizing, which is you listen, you frame and refine an issue. You bring people together if that issue has meaning to them, and you feed them. You choose an issue together to fight for. Usually you choose small. You pick a winnable battle, you win it, and then you have a big party, and then you start again. There's a famous story about a group in Chicago that did this with a local hospital. They had big problems with heart disease and HIV and lung disease and asthma. When they went about, they had public health people figuring out what their major health care struggles were, what their major disease challenges were. Rather than starting at the top, they went down the list to about number 10, and they started working on dog bites because there were packs of wild dogs running around. They figured a way to get their hands on those dogs. The dog bites went away, and they had a big party, and then they started again. God love them. You can do this. You are the people who are trained to understand the data. You are the people who know how to be in communities, and you are our superheroes. Just think of the healthcare system you will build when we stand up together and revolt. So keep your eyes on the prize, which is a healthcare system that's for people, not for profit, that provides equal health care for all Americans equally, and that strengthens, not weakens, our democracy. My teacher and mentor, Dr. Bernard Lown, said he won the Nobel Peace Prize in 1985 for triggering the nuclear disarmament of the late 70s and early 80s. He said, if you can see the invisible, you can do the impossible. You can now see the healthcare system. It is now visible. And you can do what's been previously thought as impossible because of your vision, courage, and commitment. In many ways, today we are all Ukrainians who are showing us how to make democracy happen by their courage and commitment. So join the resistance and please help lead the revolt. Thank you.
Everyone, let's get you seated up here. Thank you very much, Dr. Fine. We're going to hear from more voices now. So, ladies, why don't you come up? I also wanted to make sure I get their introductions correct. We have with us today Ana Hernandez, who's an undergraduate student in public health, about to graduate and with honors. She's a member of our undocumented community with a real commitment to health promotion, health education. Her goal is to get a master's degree in public health. I think we can help her do that.
And then go to medical school. Anyway.
And then second, we have Morgan Turner, another one of our bright stars from our MPH program here at Cal State LA. She works currently as a contact tracer in LA County Department of Public Health. She used to work as a community health worker at Harbor UCLA. She's going to bring some great perspective to our conversation today. Thank you, Morgan. And finally, Sheila Senyo, who is one of our graduates of our Cal State LA MPH program, one of our shining stars. She worked 19 years with Kaiser Permanente as a health information management analyst, but she's now currently working with the California Department of Public Health, working in their chronic disease surveillance research branch. So I invited them here so that they could work with Dr. Fine and get some answers to questions. So you have to pass the microphone around. Sheila, are you starting? Great, thank you.
So just for this. 10 minutes for this. Okay. Dr. Fine, thanks again for sharing your time with us today. Like many of us here, I really enjoyed the book. I think there are some big ideas that are important in the book. The idea that we need to change the system in grassroots level activism, which you call the movement for healthcare in America. But you know, I have worked in healthcare for about 19 years, and I've witnessed the stress that they underwent, especially through the COVID-19 heights. And doctors are already squeezed into 10 to 15-minute visit to accommodate the patients. I guess this is a loaded question, but with this clinician shortage, how can we actually get more providers to revolt? How do we even get providers to be on board? And given that there's so many problems that are more fundamental to the system, taking the attention and energy away from our doctors or nurses seems like it's a hard thing to do.
This is a hard thing to do. I want to start by reminding you that we do not have a healthcare system. We have a market, and my colleagues who are physicians and nurse practitioners and PAs have felt like they have been disrespected by that market. They've been turned into commodities. They talk about doing hamster wheel care and being subjected to a speed up where they're measured and sliced and diced, and what counts isn't the time they spend thinking about and listening to patients. What matters is something called the number of RVUs, and you'll remember RVUs from Kaiser, I suspect, the number of RVUs they can crank out. As I said, 20 years ago, they were all in practice for themselves. Now they're mostly employees, and they are rife for sort of getting themselves riled up. What they need is a supportive community that asks for their support and leadership. But I don't think they're going to be the out front leaders of this. I think the public health community is more likely to do that because, folks in the public health community know this data and know how to understand this data and know how to mobilize it. So I think, you guys are as important and perhaps more important than those professional colleagues. Now, I also think that as part of this process, we ought to triple or quadruple the number of primary care clinicians we're training, and all those people should go to medical school, nurse practitioner school, and PA school for free, and in exchange be asked to go back and practice in the communities from which they come. But that's another part of the whole picture. We got to do all of this, and it's crazy making to have to do it all. The problem is what happens if we don't.
Right. Thank you, Dr. Fine. We can start from somewhere. You also wrote, "We'll build a national political movement, a political revolution in healthcare to pass enabling legislation at the state and local level." Dr. Fine, restructuring the healthcare market into a healthcare system seems to be a monumental task to do without policy intervention. For example, how would you cap the medical executive salaries? They earn most in healthcare. I know. Or how would you reduce healthcare costs, right? And close the loopholes that allow pharmaceutical companies to raise up to 500% in the prices that they have?
Well, practically, the way to do this is to start with primary care for all. Most people don't know that primary care consumes 5% of the total healthcare budget, but is the only medical service that's ever been shown to both reduce cost and improve health outcomes. If we can get a primary care delivery system done first, then we'll reduce the cost by just sort of that by itself, improve the outcomes by itself, and begin to have the traction we need to really start to work on some of these other critical changes. But I would remind you that I think the legislative approach comes last, not first. What comes first is activating communities, being in communities, helping people understand what's actually going on, help people understand that $6,000 per person per year is basically being taken out of their pocket. That's money that, if it didn't have to go to health care, could go into salaries, so people could have a decent living and afford to have a decent place to live. So all that work all the legislative work comes second. What comes first is building the movement with widespread support, and that's where we need the help of everybody in this room.
Thank you. So as you mentioned, you want the revolt to come from the community first. With that being said, in the book, you also mentioned that really we need to lean into the pillars of democracy, get out and vote if we do want to see a change. But how do we engage groups who often experience the most negative effects of the healthcare system to get out and vote or use that change when a lot of policies have really written them out to somewhat use that vote? Is there different ways we can do that, or what are there other options?
Well, I think this change starts in those communities, that this isn't something that should be done for or to those communities, but with those communities. This needs, the way to do this, I think, is to be with people, to be in churches and in community groups, and help people or involve people in this whole process of understanding how much it costs and what the benefits of actually having a healthcare system are, so that they are involved with the fight from the beginning, so that they stand up and act up as part of this process. I think that's much more effective than just focusing on the vote. The vote will come, but first we have to build the movement. They're doing this just by trying to pass something in the legislature. It just isn't going to. It's not going to get there. Those of us who have worked in the political process know that, when something is proposed, it takes 5 years to get it through, and it gets watered down and sliced and diced, and the lobbyists come in and they know how to derail things. But it's a different thing when you get thousands of people, millions of people in communities all across the country demanding things are different. So, I think that's the way to do it. To do to sort of get things to the legislature later, build the movement first.
I love that you said not doing it for the community, but with the community. I really love that. This next question comes from one of my classmates, and I know you mentioned already about how the civil rights movement, they took a while, but they started, and you have to start somewhere. Do you think that the COVID-19 pandemic could be a start in order to change this health market into a healthcare system?
Well, if you had asked me that before the pandemic, I would have said maybe. Right now, unfortunately not. I think we have failed to look at or learn from the pandemic. We have blocked it out in a certain way because we all want to take our masks off and so forth, and because of the political division that we have. So, it could have been, but it wasn't. To me, the pandemic was the first plague of the 10 plagues that we'll probably have to go through before we are ready to make change. But it doesn't mean that we can't begin the work that it will take so that we are ready when the next plague hits, and find a way to help people see through that. I mean, I was astounded to learn things like only 10% of people of color could work from home, which is how come things spread so much in communities of color. I was astounded to learn that schools, a major role of schools when things had to shut down was feeding their students, that 50% of all meals prepared in the United States come from restaurants. Families aren't eating together, and working families don't have the means to actually feed their own kids. Who have we become? This was a look at who we are, but I think we have closed our eyes, and we need to work harder to get those eyes open.
So I'm pretty loud, so I'm going to keep this really low. So thank you for that answer, and so more the reason for us to be here, right? So thank you everyone for being here today, and this should be enough inspiration for all of us to join, right, and start the revolt for ourselves. And personally, I want to thank you for actually acknowledging one of the sad realities of the U.S. healthcare system, which you actually call a market that extracts wealth from the public. Personally, when I picked up the book, this is the statement that actually kept me reading past the introduction, because I really agree with this. And I was like, finally, a doctor who can actually admit this, right? And so thank you. I was really thrilled that a physician was, willing to admit this truth. So being a medical doctor yourself, what would you say to other MDs to accept your suggestion to actually revolt, right, against the current for-profit system that we have right now, and return to the caring physicians that they used to be, and stop worrying about just filling their pockets?
Well, what I say to people is that we've been complicit. We should have revolted ourselves, and should have stood up and should have pushed back. I have this whole little meme that I talk about. There's something called and so those of you who've done home care may know this, the health care or the home care plan of care. I've got the name wrong, but it's this 11-page document that nobody understands, that the people who prepare it don't understand it, the people who sign it don't understand it. Medicare pays for it to happen, so it happens, but it doesn't mean anything. I don't understand why physicians haven't pushed back at that and made that go away by revolting. I don't understand why people deal with the electronic medical records they have that they hate. In other countries, people love their EMRs. Our EMRs are built around billing, and they have messed up the lives of my clinician colleagues. It's time for us to stop that. And even more than that, we have some, what I call ill-gotten gains, that we've made money. I think we are paid in a certain way to keep quiet. The salaries that people make are to some degree for their service, but to some degree leveraging something that Henry Ford called the employment rent, that, you pay people enough money, they'll do what you want to do, whether they think it's right or not. It's time for us to pay that back. So I have a friend and colleague in Cleveland, Dr. Kurt Stenge, who proposed that we should start tithing, that we should start taking 10% of our incomes and sending it back into this community organizing effort. And that's the kind of thing that I think my colleagues need to start doing.
Well, that's a wonderful idea, I think, and hopefully we can all, start talking to physicians and actually have them agree. The following question, and thank you for your answer, Dr. Fine. The following question comes from one of our first-year MPH students, and he's asking, knowing that primary physicians positively influence health outcomes and decrease spending in regards to healthcare system, what are ways we can actually recruit more people recruit more people to even consider becoming primary physicians themselves? And should policies be passed to recruit people in the communities to become physicians?
So the first part of my answer to that question is to remember, as good a question as that is, that the major determinants of public health outcome aren't medical services. The major determinants are education, housing, public transportation, community development, safe streets, stuff like, and the environment. So, you know, while I'm a primary care militant and think everybody ought to have primary care, I never want us to forget those critical ideas. Now, the basic, quick, and easy way to change recruitment is to do things like make sure that primary care, anybody who's going to do primary care, medicine, nurse practitioner, or PA, does it for free. They shouldn't have to pay or take out big loans. Instead, they should have the opportunity to do what I did, which is in exchange for getting their education for free, they ought to go back and serve for 3 to 5 years in the communities from which they came. I ended up going to the mountains of East Tennessee for 3 years, which was kind of a surprise. But I got a National Health Service Corps scholarship, which were widely available in those years. We ought to bring that back for every community, and at the same time, we ought to invest in expanding our medical schools, nursing schools, and PA schools by a factor of 3 or 4. So we are training way more than we train now. The actual cost of doing that is kind of a rounding error. It's what we call budget dust. It costs relatively little compared to the value that it generates. And one of the things that you learn after spending time in this so-called mess, this system that is more a mess than a system, is that nobody's in charge of all that. There is nobody in charge of figuring out how many physicians, nurses, and PAs we need and making sure they get trained. What actually happens is that medical schools, nursing schools, and PA schools just decide that they're going to open up, and then we all hope for the best. That's crazy. We need a healthcare system that sorts out what we need to accomplish and then recruits the resources to get that stuff accomplished instead of just hoping for the best. We hope for the best with health professional education. We hope for the best with hospitals. Nobody decides that for hospitals. We decide when there are too many hospitals, but not when there are enough. We need that for primary care practices. The reason that there aren't primary care practices in every neighborhood and community is that nobody's in charge of making that happen. So we need to get this thing going, make a system out of it, and put somebody in charge of doing what we need to do to deliver on public health outcomes and do it for a cost that's affordable and with outcomes that we can be proud of instead of ashamed by.
Thank you, Dr. Fine. I also want to address one of the questions brought to us by our colleague. To what extent should we blame the failures of the system? I know the system is broken, but...
No system, sorry.
On the values held by our leaders and citizens. For example, we have shorter lifespans compared to other developed nations. And maybe because we are more stressed here in US and we have more competition, we have less willingness to see that we all get adequate health care. Or maybe too much advertising on obesity and heart attack producing foods, right? And on our end, little activity. In other words, we are a democracy. If we had values that cared more about making sure we all got what we needed health-wise, we could perhaps fix a lot of these problems. Do you think maybe the problem is not just the system, but us?
Well, I don't blame anybody. I don't think that gets us anyplace. You know, it happened. I'm embarrassed about it. It's ridiculous. It's expensive, and it's harmful. But me beating up on, you know, who did it isn't going to get us anyplace. Our job is to fix it going forward. And I think that's the real critical idea, that we got to fix it going forward. And the way to change it is for everybody to get involved.
Thank you, Dr. Fine.
We have 5 minutes. So if you want to take questions from the audience.
Yes, Are there any questions from the audience? We have a few more minutes. Yes.
So you started off as a physician. Have you always thought the system was broken, or did you kind of like realize it during your career?
So the question is, I started as a physician. Did I always realize that things were broken, or did I realize it, along the way? So truth is that I didn't start off as a physician. I started off as a community organizer in the South Bronx. I went to medical school because I thought healthcare was a great focus for organizing. And so what I then saw confirmed it in more ways than one. Someday when we have more time, I'll tell you about working for a corrupt cardiologist. Oh, you don't even want to know. It is so messed up as not to be believed. But I went in like this. And the miracle is that the medical education process didn't drum it out of me. One of the things that when you asked about physicians and trying to, get physicians to change, like everybody else, I think there's fairly substantial trauma in the process of medical education where people are really made to feel like dirt. Yes, they make a lot of money, and I don't want to overdo their sort of histories. But if we're going to build a system, we've got to find a way to recognize everybody's injury, respect everybody's injury, and then help everybody heal together. They didn't go in like this. Most of them are good people. Almost all of them are good people. But they got badly beaten up along the way. And yes, they get paid well, but, it probably doesn't compensate for what they lost in terms of their inner lives.
Thank you, Dr. Fine. I know that we have more other questions, but our time is limited today. So on this portion of the Q&A has been very insightful personally and hopefully for everyone else. On behalf of Anna, Morgan, and myself, I'd like to thank you again for the time that you shared with us. I'll return it over to Dr. Stevens.
But before we do that,
Yes.
Can I thank the three of you and everybody else who's here? And can I thank Dr. Stevens for his amazing commitment and advocacy?